So Ali Rowhani-Rahbar is the Bartley Dobb Professor of the Study of Prevention of Violence at the University of Washington. He's the Violence Prevention Section Leader at Harborview Injury Prevention Research Center, and he is also serving as an elected board member of the Society for the Advancement of Violence and Injury Research, which of course I have to give a shout out to as well. And we're going to hear him talk about helping individuals with firearm injuries, a randomized clinical trial.
Thank you, Joel. Good morning, and thanks for coming. It's great to see you all here. As Joel mentioned, I'm going to talk to you about one particular study that's an ongoing study currently at Harborview Medical Center in Seattle, Washington. The study is ongoing, so as of yesterday when I was talking to my project manager, we have enrolled about 225 patients. I won't be able to present results of this because we are still enrolling patients, but as we were talking with other members of the planning committee for today, we were considering talks that might be helpful in terms of expanding our horizons and ideas about how to think about some of these work, whether ongoing or done, to hopefully inform practice and policy moving forward. The work that I'm going to present to you has been funded by several different organizations and agencies, including Department of Justice, the City of Seattle, and Laura and John Arnold Foundation. And really, I'm presenting here on behalf of a large group of colleagues who have been really working hard on this for the past several years. It's just really, as you know, can't be part of work of one person. But before I start talking about firearm injury, I want to take you all back about 30 years ago, more than 3 decades ago, when first published in JAMA and then some other journals, in the field, it was very clear that individuals with trauma who misuse alcohol are at really high risk of re-trauma, recurrent injury again. So after those observational studies were done, one of the first randomized trials of doing something about it, which would be an intervention, a brief intervention, motivational interview based, was published in Annals of Surgery, entitled Alcohol Interventions in a Trauma Center as a Means of Reducing the Risk of Injury Recurrence. And the hypothesis that the investigators had in mind was the following: providing brief alcohol interventions as a routine component of trauma care would significantly reduce alcohol consumption and would decrease the rate of trauma recidivism. So this is a very seminal study. Many of you who are in the field of trauma are familiar with this seminal study. What happened was that when they looked at the findings, they found out that not only does it reduce the, if you will, the intermediate outcome, which is how much actually people drink. As you see the intervention group and the control group. In the intervention group, you can see those are the change in mean number of drinks per week that steadily goes down over a 1-year period. Not only that, but also when you look at the final outcome of interest here, which would be injury, this is over a 1-year period, those individuals who came back to the trauma center. You can see with a hazard ratio of about 0.53, that translates to 47% reduction in risk of recurrent injury, a profound and meaningful reduction in risk of recurrent injury here. So fast forward, many of you are aware now that this has now turned into routine practice. Not only does it impact the main outcomes, such as recidivism that we care about, but also some other outcomes that you see in this picture. They recommended at that time, as part of the conclusion of their paper, that the prevalence, because of the prevalence of alcohol problems in trauma centers, screening, interventions, and counseling for alcohol problems should be routine. That's the conclusion of that research article. And today, in these days, as many of you know, this has been endorsed almost as a mandate by the American College of Surgeons and many other organizations, that trauma centers are required to identify at least one member of the trauma staff to receive training in how to administer these screening and brief interventions to monitor and evaluate program activities. So what does this have to do at all with firearm injuries? So I think part of the reason that we are getting together today is to talk about things like this, how we could translate evidence into program and policy that could save lives and change lives and move the needle. So right after the tragedy at Sandy Hook Elementary School happened, we were fortunate to receive some funding from the city of Seattle to launch a statewide study to look at individuals who had been shot and they had been hospitalized because of a gunshot wound anywhere in the state of Washington, and look at the risk of their subsequent victimization and perpetration and involvement in the cycle of violence. That work resulted in several papers, 2 of which are presented here to you and published in Annals of Internal Medicine, where we essentially quantified the risk of these outcomes. This was an observational cohort study, the first one, and then secondly, we did a cohort study and a case control study to essentially look at some of these upstream risk factors that my colleagues mentioned, and you'll hear more about that during this morning session, and also some of the final outcomes, such as exposure to criminal justice system and also healthcare system. So this is the anatomy or architecture of the design, if you will, where we look at all those individuals who had been hospitalized because of a gunshot wound anywhere in the state of Washington in 2006 and 2007. Then we did probabilistic record linkage to their hospitalization data, the arrest data, and conviction data, both backward and forward, to get a good sense of a decade of their life, to see what happened to them before they were shot, what happened to them after they were released from the hospital. So I don't want to go through all the details. There are a ton of data there in the paper, and I'm happy to talk to you about it more. But just to give you maybe one important part of it, so you can see these are subhazard ratios that essentially quantify the risk of subsequent injury and death. Here, this is just hospitalization I'm showing you. And you can see, for example, the numbers speak for themselves, that individuals who had been shot and they had been hospitalized, they were 21 times more likely to get shot again and come back to the hospital, which was profoundly larger than any other group that you could imagine, even people who had been assaulted, but not with a gun. So these results really showed us, not that we didn't know that these individuals are at risk of getting shot again, but really showed the magnitude and scope of the problem and was quite powerful. Then we also looked at perpetration and arrest. I should say arrest, maybe that's a better term than perpetration, because it really shows exposure to criminal justice system. It's a complicated, multifaceted issue, as you know, with issues of institutional racism, etc. But we looked at the records in terms of arrest, and we compared people with firearm injury with other injury types and also new injury to see what is the risk of their getting arrested over a course of a 5-year period after they are released from the hospital. And you can see, if you look at the black line, the solid line, again, the firearm injury group completely stands out compared to other injury groups. Interestingly, to your left, you see the assault group, and to your right, you see the individuals who had been shot, but the label that they had received in terms of intent was unintentional or accidental, quote unquote. And you still see that even in the right-hand side, there is a large risk of exposure to criminal justice system and getting arrested among those who had been accidentally, quote unquote, shot. So colleagues from the National Network of Hospital-Based Violence Intervention Program, several of them I see in this auditorium are sitting here. Carl is going to talk about them later. Joel is heavily involved in that. But these wraparound programs have been around for a long time. But the National Network was established around 2009 formally, that really utilizes a trauma-informed care principle and philosophy, using the teachable moment to interrupt this costly cycle of violence. So when we saw those results, obviously the first thing that people in the state of Washington and in the city of Seattle and colleagues around the country were asking is, so what to do with this? We have provided evidence that this is a very high-risk group. What are we going to do about that? And Carl is going to summarize the state of the art on this, but based on the systematic reviews that have been done and ongoing work, while there is an accumulation of good evidence that these programs work and they are cost-effective, still we have a long way to go to provide more and more evidence based on research, both in terms of effectiveness, but also implementation, as Renat will talk about, of how to actually roll these programs out. So we launched HiFi, Helping Individuals with Firearm Injuries, which is an ongoing randomized controlled trial at Harborview Medical Center, focusing only among people who have been shot and they present to Harborview Medical Center. The unit of randomization, for a large number of reasons, which is beyond the scope of this talk, mainly methodologic, was calendar week. So what we do is that a study staff assigns these individuals who come to Harborview Medical Center with a gunshot wound either to the intervention or to usual care based on calendar week. And we will try to wrap up the study by the end of 2019, so papers will come probably in 2020. The intervention has 3 different components: a motivational interview component, which is the first component of these 3-component intervention, usually done at the bedside or in the ED, where the support specialist tries to connect these individuals to the CTI, or critical time intervention component of this, which I will talk to you about, which is at the heart of the intervention. And then there is multi-agency attention. We call it MDT, or multidisciplinary team. Colleagues from and the community services, law enforcement, mental health, employment, education, housing, all those community services that Mike mentioned, and you'll see will be a common thread, as Joel mentioned, in many of these type of work when we do case management, that are there to help our support specialists help these individuals. Through conversations with colleagues in Center for Advancements of CTI Studies in New York City and some other individuals, where we were trying to get at what would be a good evidence-based program to actually implement, we ended up using CTI, which historically, back in 1970s and 1980s, had been used in New York City among homeless men, especially men of color, where they were going from, from an unstable housing to stable housing or vice versa. And we thought it would be an innovative adaptation of that to try to use that for people who have been shot. So you can see different phases of CTI. The pre-CTI is developing a trusted relationship with the patient, and then through different phases that tapers off, it goes, in terms of intensity, it goes from high to low. The support specialist works in a time-limited, time-defined manner over 6 to 9 months to work with these individuals to ensure that by the end of the intervention, the support network is in place. In terms of measures, again, as Mike mentioned, and you'll see in the presentations that Rebecca and Kyle and others will present, many of these do overlap. So it's a combination of self-reported, patient-reported outcome, which, as Mike mentioned, is quite important, but also a large battery of administrative databases that we have in Washington State, from criminal justice system to hospitalization, to really try to get a good sense of some of these outcomes among these patients. We try to get this information at 1 month, 3 months, 6 months, 9 months, and 12 months. So it's a lot of repeated measures. And the reason for that is to try to ensure that we don't lose these patients, because it is very, very hard to retain these patients for reasons I will mention to you. Based on the past 2 or 3 years I've been working on this, there have been lessons learned. This is not easy work. It's tough work. But what keeps us going is the meaning behind it. I've had several conversations with Ted Corbin, John Rich, some other colleagues who are doing beautiful work as part of the Healing Hurt People, and other colleagues in National Network about some of these challenges. Maybe this is one way of summarizing the 3 main challenges that I have faced in the study itself. One is cost. People who are shot, they come to trauma center at any time of the day. You want to have 24/7 coverage, it does require money. On the flip side, when you think about the cost of violence and how much it really costs in terms of not only medical costs, but also societal costs and lost productivity, the cost related to the implementation of this pales compared to that. Socioeconomic position, poverty, low income. These are individuals who have difficulty sometimes even commuting from their residence to the trauma center, so they need voucher or help in terms of those. They're very mobile. Their addresses change all the time. So it's really hard to make sure that you really need to work hard to ensure that you stay in touch with them. And lastly, I would say systems avoidance, distrust of authorities and institutions, entrenched issues like institutional racism, etc., that you are really familiar with this. So it really requires somebody like a support specialist or case manager with lived experiences who knows their pain, can work with them, can talk to them, and truly, guided by elements of trauma-informed care, try to change their lives and make it better. I'm going to wrap up with this one slide. While I'm not showing you any results just yet, we've enrolled about 230 patients, 225 patients so far. Hopefully we'll get to 250 by the end of the year. I would say that some of the things we have found that have kept us going and have motivated us for this type of work is some of these quotes that you see here. One of our fellows has just started doing a qualitative study among these patients, which I'm very, very excited about because those qualitative studies will give you a lot of information. But you see some of these quotes that really makes us quite happy doing this type of work. I'll just end by saying that I think we all have a duty, which is raising awareness about these hospital-based violence intervention programs. We need to do enhanced communication among those involved in the implementation and evaluation of these programs. And I can say that, the more advocacy, the better to really get additional resources for this type of work. I'm happy to answer your questions maybe in the Q&A session. Thank you very much.
Thank you.